Okay, imagine this. You walk into a clinic for a really serious diagnosis, only to find out your doctor hasn't actually read a single medical journal since 2010. There is no way you trust their treatment plan, right? Well, in the cutting-edge world of medical AI, this exact scenario is playing out every single day. Welcome to our explainer. Today we're unpacking a truly fascinating presentation by Dr. Anguraj Sadanandam, and we're looking at the hidden, frankly surprising dangers lurking in the data that powers medical AI. There's this fantastic quote from Dr. Sadanandam that hits the nail on the head. He says, like medicine, data also has expiry. We kind of tend to think of digital data as immortal. It just lives forever in the cloud. But in the incredibly fast-moving world of oncology and medicine, AI models can become obsolete just as fast as medical treatments do. Because if an AI is trained on expired data, its recommendations might belong in a museum, not a modern hospital. So, how exactly does medical AI expire? In this explainer, we are diving deep into the intersection of artificial intelligence and oncology to figure that out. We're going to look at why having more data doesn't always mean having better data, and how the actual age and location of a dataset can drastically change patient outcomes. Let's dive right into this. Here is our roadmap. First, AI's expiry date. Second, biology versus treatment. Third, the dangers of outdated AI. Fourth, medical AI geography. And lastly, we'll cover the 3 golden questions you need to be asking. Starting off with Section 1, AI has an expiry date, the hidden lag in medical data. To really grasp this expiry date concept, we have to think about the fuel that powers these tools. AI learns from data, obviously, and in medicine, the vast majority of that data is what we call retrospective, meaning it's collected from past patient samples that have been sitting in biobanks for years. Now, this data is absolutely invaluable for understanding the deep biology of tumors. But here's the catch. The treatment guidelines attached to those past patients reflect the medical standards of that specific era, so they might not be current anymore. And because of that, we are facing a massive lag. According to Dr. Sadanandam, it takes, on average, 5 to 10 years for a biomarker discovery to move from a lab all the way to a functional clinical AI tool. Think about that. By the time a model is finally trained, validated, and pushed out into a clinic, the data it actually learned from is already up to a decade old. Moving to Section 2, biology remains, treatments change. This is the core dichotomy of medical AI. What's really interesting about this is why that 5 to 10-year lag is such a massive problem. We are dealing with 2 completely different timelines operating at the exact same time. On the left side of the equation, tumor biology stays constant. A stem cell's characteristics today are going to be exactly the same 100 years from now. But on the right side, oncology treatment guidelines evolve radically every 2 to 4 years as new drugs hit the market. It's this connection between biology that stays the same and treatments that constantly evolve that actually expires. And honestly, this busts a huge myth we see a lot in the tech world. The idea that just having more data automatically equals better AI. But the reality is, you could have 11,000 tumor samples in your database, but if they don't have any modern treatment information attached to them, you only get a biological picture. You don't get real-time clinical decision-making power. You just can't guide a doctor today using a massive data set of outdated treatments. Which brings us to Section 3, the danger of outdated AI and the real-world consequences in oncology. Let's look at exactly what this means in practice by tracing Dr. Sadanandam's own pioneering work from back in 2010. By looking at it objectively, we can literally see the real-world consequences of medicine moving way faster than AI. Just look at this timeline. So back in 2011, the standard of care for pancreatic cancer was a drug called gemcitabine. Fast forward to 2016, landmark trials for gastric cancer leaned heavily on aggressive ECX chemotherapy. But today, doctors are using highly aggressive treatments like FOLFIRINOX and PARP inhibitors. If an AI tool was trained back in 2011, it has literally zero idea that these modern standards of care even exist. So Dr. Sadanandam poses a really visceral question. Would you treat a colorectal cancer patient today using an AI model that was trained before immunotherapy was an approved standard of care? I mean, obviously the answer is no. If an AI doesn't even know about modern immunotherapies or extended RAS testing, relying on it could lead to flat-out incorrect, outdated diagnoses for patients sitting in the clinic right now. And it gets even more complex, because it's not just the drugs that change, it's the actual technology we use to gather the data in the first place. Early AI models use something called bulk RNA sequencing. Dr. Sadanandam compares this to a bird's eye view on Google Maps. You can see the whole city, but it's pretty blurry. Today, we use single-cell spatial data. This is more like a street-level CCTV camera. You can see exactly what individual cells are doing and who their neighbors are. If your AI is still staring at a blurry Google map from a decade ago, it is missing absolutely vital high-resolution insights. Let's shift gears to Section 4, the geography of medical AI, why location and population matter. Because an AI's expiry date isn't just about when it was trained, it's also about where. This is called generalizability. Take a look at this data comparing cancer prevalence. In the Western world, you see a higher prevalence of colorectal cancer and lower rates of triple-negative breast cancer. But if you look at India and Asia, the whole landscape flips. They have a lower prevalence of colorectal, but much higher rates of triple-negative breast cancer. So if you train a brilliant AI model exclusively on European patients, it might completely misread the unique biological landscape of a patient in India. As the source material bluntly points out, one cohort is not every patient. Population matters. You cannot just copy and paste an AI model halfway across the globe. Patient lifestyles differ, prognosis patterns differ, regional biology differs. An AI trained in London 30 years ago reflects the lifestyle and data of London 30 years ago. It absolutely has to have rigorous local validation before it can be used safely anywhere else. And that leads us to Section 5, ask the 3 golden questions. Basically, your checklist for medical AI. So we've seen how AI can fail both chronologically and geographically. The big question is, how do we protect ourselves? Well, Dr. Sadanandam outlines this incredibly straightforward clinical checklist. Step 1. Who was studied? Is the population actually relevant to the patient in front of you? Step 2. Where was it developed? Has it been tested in the region it's being used? And step 3, which might be the most crucial, when was it trained? Does its training era actually match how we treat cancer today? To answer those questions with any real confidence, the medical community has to demand rigorous validation. We need internal temporal validation, so proving the tool holds up over time. We need geographical validation to make sure it works across borders. We need external validation by completely independent cohorts. And the gold standard? We have to strive for prospective validation, actually testing the AI in real-time clinical trials instead of just relying on dusty, retrospective data pulled from a biobank. The underlying biology of human disease might remain constant, but our weapons against it evolve incredibly fast. An AI is truly only as smart as the era it was trained in. So I want to leave you with this to think about. The next time an AI tool gives you a medical answer or recommends a life-altering treatment, will you actually know how old its knowledge truly is? Thank you so much for joining me on this explainer. Until next time, stay curious and keep asking those golden questions.